Thank you, Sendhil sir, for giving me this opportunity to go live today. And we have a case of 50-year-old male patient came with the abdominal pain in the central and epigastric area for a short duration, and there is surgical history of open ventral umbilical hernia repair in 2014, and now the patient has a small swelling on with cuff impulse in the left inguinal region and a swelling in paraumbilical region. And on scan, he has gallbladder stones, although scan-wise there is no inflammation of the gallbladder wall.
So what is the plan?
So plan is, I'm putting the diaglab first. Let us see how the adhesions are in the area of the incisional hernia area. And we will go ahead with lap chole first, probably followed by adhesiolysis, left hernia repair, and then IPOM.
All in one go?
Yeah, if gallbladder is normal, yes. If gallbladder is not inflamed,
And if even if it intraoperatively, suppose there is any biliary spillage or anything happens, still you fix with the plan of IPOM, is it? IPOM plus?
no, usually then we avoid putting a mesh.
No, then you can do the anterior liquidation repair.
Yes, that we can do. But if it is a incidental finding of gallstone on scan, where we were treating a patient of incisional hernia or inguinal hernia, even with spillage, we have put in mesh in few cases.
And now since this is an operated case of umbilical hernia before, where do you, because we are seeing you, we are not seeing the patient where you are tapping the abdomen. So can we have that view where you have gone in for the varies to create a pneumo here in this case?
Yeah, yes, sir.
Are you going through the Palmer's point?
Yeah, I've gone
that's
to
what
the.
I wanted to.
Right.
Yeah, I've gone to the Palmer's point, the left subcostal area. You can see the swelling. It is given only on one side.
Yes.
I can see swelling on either side here. Here you can see the midline scar. And the scar extends 5 centimeter above the umbilicus and almost 5 centimeters below the umbilicus. You can appreciate that the swelling is more on the left side of the scar, and we have already insufflated the abdomen completely. The pressure is raised to 14 millimeter of mercury. Now I'm putting in 5 mm diagnostic trocar at the Palmer's point to have a look of the hernia site, and after connecting the CO2 will get in. So here I have diagnostic laparoscopy here. The liver looks normal. There is probably no adhesions in the gallbladder region. You can appreciate a defect which is more on the left side of the midline.
What was the repair done before you said for the umbilical hernia? What is that? It was open hernia.
Open hernia.
With mesh plastic.
Can you see the scar on the outside?
Yes, we can see the scar. We have
Yeah.
inside view, outside
So this
view
is
both.
the umbilicus, and this is scar above the umbilicus and scar below the umbilicus.
Yes.
And you can notice the swelling here, which is bigger, a smaller swelling here. Probably a Swiss cheese defect there.
Okay.
I do not see any left-sided inguinal hernia. Let us see with the head down little later.
Piyush,
Yes, sir.
you use the Palmer's point.
Yes,
Now,
sir.
there is an Indian surgeon called Nutan Jain. She has also come out with a point.
Jane's point.
Jain's point, yes.
Yes, sir.
Can you just tell the audience what is a Jain's point? Just to educate them. I'll tell them. It is the point on the anti-axillary line between the costal cartilage and to the anterior superior caudal spine, and midway between that at anterior axillary line at the level of the umbilicus. So this is known as Jain's point, which is becoming popular, and
Yeah,
she's
they connect.
done a lot of research on it and found that it is equally good as
Couldn't
a
stuff
Palmer's.
first either put.
And she's an Indian, so we are proud of it. Somebody has come out with a different point, Jain's point.
So I am entering through the scar, the 10 mm, which is close to the hernia defect.
So you are concentrating on cholecystectomy here first.
Yeah, yes, sir.
But is it not a good idea to bring down this content first and go through the defect and hernial sac only directly with this 10 mm?
That is fine, sir, but it will give a very flat view of CVD. So usually we always go above umbilicus in any other cholecystectomy as well. So the defect is almost like at umbilicus or below it actually, and probably it will be too far. If you can observe here, this is subxiphoid area, and this is the defect area
Okay.
outside.
Okay.
So I think that this distance will make a difference for view of the CBD. And probably because we are covering the scar anyway, we will cover
Yeah, I
this
think
port area as
that's
well.
the point. You're going to cover this puncture, so anyway, it does not matter whether you do it there or a little above.
So what would you advise, sir? Because patient was planned for cholecystectomy. There was history of epigastric pain. Endoscopy, other than mild gastritis, there no.
The primary surgery is cholecystectomy, what is
Yeah.
planned as per the symptoms of the patient.
Yes, sir. Yes, sir.
See, you have to do the first surgery when the patient has come far.
Yes,
The
sir.
second surgery is optional, depending on what you do.
Complementary. Okay, at your center, I mean, since the things are happening, we can just discuss about at your center. Have any experience about the pre-peritoneal mesh placement in case of these ventral hernias?
So you mean the other procedures?
Yes, other
Like,
procedures.
yeah, we do here ETAP. For ventrals, we have done TAPP plus, that is just like raising the peritoneal flap, closing the defect, and placing a polypropylene mesh. Head up, please. Head up. And we have done few TAMs also, that is transabdominal retromuscular repair of the ventral hernia. Yeah, yes, sir. Which Dr. Ashwin Masurkar is also with us, the inventor and the innovator of the TAM procedure.
Yes.
So it is traditional 4-port surgery, where usually our camera port goes 3 to 4 centimeters above the umbilicus, which gives a better overview of the CBD, and the view is over the CBD rather than a flat view of CBD, which is very important in few difficult cases of cholecystectomies. And as a protocol, we follow the optical trocar always above the umbilicus. So it looks normal thickness of the gallbladder. So the fundal retraction is such an important step. It should be in correct direction and with adequate traction, and that will open up the hepatocystic triangle, and that prepares our beginning of the dissection. Can you appreciate the Rouvier circus? Not so obvious,
Yes, not
but
so
still
obvious,
it is seen.
Yes.
Yes. And you can see the course of CBD also here.
Yes.
Yes.
And this is duodenum, which I have taken down a little bit here.
Yes.
And infundibulum of the gallbladder, which is in my left hand.
Yes.
So this is the Rouvier circles. So this is an imaginary line, R4U line, which extends from Rouvier sulcus to the umbilical fissure at the base of segment 4, which divides the area. The above area is safe and below area is unsafe. And you can very well see that this will guide us towards the dissection, a safer dissection while achieving the critical view of safety. And we can just imagine this line in every case of laparoscopic cholecystectomy. So my plan of dissection will be above this. So this must be the right hepatic duct somewhere here and probably CBD somewhere here. So I'll be keeping myself above in the safe area.
Rouvier circus, there are various types. In about 5 to 10%, the Rouvier circus may be totally absent. In another 10%, it may be just a small line, nothing more than that. And in other 60-70%, it may be a complete sulcus. So these are the 3-4 varieties of Rouvier sulcus. So don't always feel that the Rouvier sulcus will be visible. It may not be visible at all in 10% of cases.
Another thing is the instrument which is to be used. So there are choices what people have while doing this dissection. As he is using monopolar Maryland here, some people use a bipolar Maryland here, for this dissection. Some people use hook. for that. Many of them, hook, spatula, these are the different instruments people tend to use for this dissection.
So my choice is purely what I learned from Sendhil sir.
Yeah, so it is
And
monopolar Maryland.
yeah, we have the bipolar in hand here actually. But
Huh.
I would prefer to go with what we use
Yeah, whatever
usually.
you are comfortable and your practice and you know what you can use the best, I think that is what is works good.
So, like we always say that you have to enter the trocar where the fat and peritoneum meets here, and that will be comfortable. Exactly here,
Yes.
you have to just follow the line where the fat is embedding over the peritoneum of the gallbladder.
Actually, you can go slightly down. No need to go because you're always at the infundibulum, and the infundibulum is very thin. So you can go little below, Piyush.
Yes, sir.
Otherwise, you might land up
Current passing there can cause a bit of a trauma and
In
puncture of that
in
gall.
puncture the
Gauss
infundibulum.
persons.
It's a thin walled gallbladder.
So here very important is the direction of the monopolar or bipolar, whichever instrument you use. It should be directed above.
Maryland has the
And-
advantage of using it as a dissector as well. I think that is one best advantage this instrument has when you
Yes.
use it for this.
So I can just mobilize the cystic duct here itself if I have the
Yes,
Maryland
yes.
here. Basically, we have to isolate cystic duct and cystic artery to create two windows. It will offer a view of the liver surface lateral to the gallbladder bed when the camera is in medial position. And this particular aspect is referred to as critical view of safety, which we are gonna see soon. So here you can see the node of Lund, and the dissection will remain always above the lymph node. And you can take down the lymph node as well. And the peritoneal reflection or the gallbladder goes in upward direction and not towards the porta hepatis. And this is again a very important thing to remember, that keep yourself above the node of Lund. Now you can see that these are the small arterial branches which are going from the cystic artery to the cystic duct, supplying the duct, which we have to meticulously coagulate before we proceed to open up the triangles. And here you can see that I'm taking down the cystic lymph node of Lund, and I'm trying to open up the space between the cystic duct and the artery. So once there are only flimsy tissues, you can try probing your Maryland very close to the cystic duct so as not to injure any organ below and the duct as well, and also the gallbladder, while taking down all these fibers. Slowly you will appreciate that you are having only two structures which are getting inside the gallbladder.
I think you are establishing the critical view here.
Yes, sir, exactly. So I'll go a bit more above, at least 1 to 2 centimeters.
Otherwise, it is not a very big deal. But since you are planning to do that hernia along with that, I think that is what is.
Yeah, that is the main worry actually.
Main worry. Otherwise,
We are not at all worried about opening of the gallbladder. So now at almost like 1 to 2 centimeters above here of dissection,
Yes, excellent
I
window
can
create.
see only two structures which are entering towards gallbladder.
if you take out, then you will demonstrate a cystic plate there.
Yes, sir, I'll do that, sir. I'm a bit slow because I'm just worried about.
No, no,
No, no, you
Gallbladder.
take your
doing
time.
good.
You're doing a wonderful
You're
job.
doing good. You're doing good. You're not slow.
Thank you, sir.
That is enough. I think that is you are already.
Is that okay, sir?
Yeah, absolutely.
Critical
Now it
view
is
of safety.
perfect.
You can see the cystic plate there,
Yes, yes.
Correct.
and you can see only two structures entering here. So if you allow, I may clip the duct and artery.
Show from both the sides. Flip the gallbladder.
Sometimes we see that small stones which are probably lodged in the infundibulum during dissection if they have moved towards cystic duct, which were not otherwise there during scan or even symptomatically. So here we are clipping the cystic artery first. There are two clips placed on the body side, that is proximal side, and one clip on the specimen side. Similarly, after milking the cystic duct, we have blocked on the distal side of the duct, and we are placing two clips on the body side and one clip on the specimen side. And then we divide artery first and followed by the cystic duct. Here I am placing two and another clip on the specimen side just to prevent any spillage, because we are going to do the hernia next and we have to place a mesh. So it is just for a safety. So I have just clipped and divided cystic artery first, followed by cystic duct. Usually we do not clip doubly on the side of specimen, but I have done that with another large clip again.
I understand what you're trying to ask, because we milk it so there are less chances of stone remaining into the duct.
You can flip the gallbladder in the medial to lateral to see the other aspect, and then go forward for the dissection of gallbladder from its liver bed. You can keep pushing the cystic plate towards the liver bed. You can also use the heel of the hook instrument few times whenever you find that hooking of those particular fibers is not possible. And be careful that all the vessels which are passing by just beyond the cystic plate do not get injured. So always dissect the peritoneum of the gallbladder for some few length, and then make the dissection, that is separation of the gallbladder from the cystic plate. That will allow better retraction, and that will allow less injury of the liver parenchyma and the Glissen's capsule. This is one of the dissection which every beginner should learn as a first step in gallbladder surgery. Probably this is the first step which every mentor will give to his mentee. Once you are thorough with this particular step, probably you can switch yourself to the hepatostic triangle dissection, clipping, dividing, and obviously the whole laparoscopic cholecystectomy. Again, according to guidelines, the gallbladder separation from the liver bed has to be by remaining very close to the gallbladder. We have to leave cystic plate which is attached to the liver, which will avoid any bleeding. As you can appreciate right now, that we have fibers between the cystic plate and the gallbladder, and which are being tackled by the hook forceps. You have to give good amount of traction on the gallbladder to make sure that you are not injuring the cystic plate you are not injuring the liver as well as you are not injuring the specimen, that is gallbladder. So you have to be very patient, especially at this particular stage of the surgery when you think that surgery is over, but it is not yet. This is one step where we have seen many beginners injuring the gallbladder and spilling the bile. Be careful, be patient, be slow, and that's how you will win the race. Back. So usually this gallbladder otherwise might not require a bag. I'm using endo bag here so that there is no spillage of bile anywhere in the wound also. So usually we will be using a different set of instruments if we go from gallbladder to the hernia surgery in the same patient at the same setting. So here I can give a small tip that on the endo bag you have to make small cut on one side so that you can handle it little easier, and then the bag is removed from the subxiphoid 10 mm epigastric trocar point. Do it very carefully, don't puncture the bag at this particular stage. So this endo bag will prevent any spillage of the bile or infected content into the trocar site. These endo bags are made here itself in our OT by our nurses using the camera cover usually. Now we're getting in again in the subxiphoid area. So here in this particular case, we would like to exchange the suction tube and cannula both. So I'll just inspect the clipped area once, slowly lift the lever and have a look at cystic artery. Both the clips are patent there and the cystic duct. Okay, and this is the Rouvier sulcus. So that looks okay. We could make it without any gallbladder bile spillage. So probably we would go for our next planned surgery